Hi, I'm Dr. Christopher D. Simone. I'm an electrophysiology fellow here at Mayo Clinic. Today I'm here to discuss a review article in an upcoming Mayo Clinic Proceedings article entitled Supraventricular Arrhythmias, Clinical Framework and Common Scenarios for the Internist. I'm an author on this paper, as well as Dr. Nyata Natsuk, as well as Dr. Samuel Ashervatham. In this article, we give an overview of supraventricular arrhythmias, guided for an audience of general internists, so that the folks that are in first contact with the patients have a good overview of supraventricular arrhythmias, the pathophysiology behind it, and hopefully this will lead to improved outcomes from our patients from an understanding of our intervention points and how we could make our patients feel better when they have symptoms from this disease. We go into great depth in our review article, but we wanted to go over a few slides to make it more informative and more interactive. So in this first slide, our first branch point of regular narrow complex tachycardias is based on the RP interval, or QRS to P wave, or ventricular to atrial depolarization. We break these into long and short RP intervals. The long RP tachycardias include sinus tachycardia, or focal atrial tachycardia, looking at positive P wave deflections in leads 2, 3, and AVF, a biphasic with a terminal negative deflection in V1, and of course sinus tachycardia. As you'll see reading through the paper, we have certain reasons why folks could have this. It's a normal physiologic response to a certain stressor, fever, an illness, hypoxia, anemia. Focal atrial tachycardias kind of should be thought of as having a non-sinus P wave morphology. So what we just described for the sinus tachycardia, the P wave morphology will be something different. Could it be on the septum? Could it be coming from the pulmonary veins? Could it be coming from the coronary sinus? And these will have different, as we go into the paper and discuss, different morphologies that kind of guide you where the origination comes from. The short RP intervals are ones that are more amenable to interventions such as beta blockade, AV nodal blockade such as calcium channel blockers, or even catheter-based interventions. And this is important because these can have a high chance of cure if we bring the patient to the electrophysiology lab. And some of these, as we'll see in the next slide, can have a pseudo R prime, what we call in leads V1, or a pseudo S wave in leads 2, 3, and AVF, the inferior leads. In ORT, you'll see possibly negative P waves in the inferior leads because you're coming from low to high, you're coming from the ventricle back up to the atrium. And you'll see a negative deflection sometimes in 2, 3, and AVF. In this figure, we split up into the irregular narrow complex tachycardias. When you see the absence of P waves or the absence of electrical activity that manifests on the EKG with irregular patterns of QRS, that's what we classify into atrial fibrillation. Especially what you want to hone in on is something where we go into the article and discuss in more detail is typical atrial flutter. These have negative sawtooth or flutter waves in the inferior leads, leads 2, 3, and AVF, and a positive flutter wave in lead V1. This is very important because these could be easily treated and cured in the ablation laboratory. Something that has 3 or more P wave morphologies is what we define as multifocal atrial tachycardia. And that means these sites of firing in the atria are coming from different sites in the atria, different sites having different P wave signatures on the EKG, and thus cluing us into this tachycardia. Here the object is to treat the underlying cause. Sometimes it could be, most likely it's going to be a respiratory or lung disorder. This image is one where we could provide a high chance of success of curing a patient. Sometimes patients will come in complaining of palpitations or pain in their neck, dizziness or fatigue or lightheadedness. And correlating those symptoms to an EKG can be huge because we could really offer a treatment for these patients. Because if we're able to correlate symptoms to the rhythm on an EKG, we're able to better define and thus treat the arrhythmias. Here we want to talk about atrioventricular nodal reentrant tachycardia, or AVNRT. This is important because patients come with these symptoms, and we could treat these with AV nodal blockade, such as beta blockers or calcium channel blockers. And these have a very high success, maybe 95 or even higher % chance of success with typical AVNRT and catheter-based ablation in the electrophysiology lab. So these are patients that would benefit from early referral to cardiac electrophysiology. You notice on the left side, in sinus rhythm, we have two inputs into the AV node. One, which we term the fast pathway, one in which we term the slow pathway. In normal sinus rhythm, you have conduction going along the atrium. One's going down the fast pathway, another's going down the slow pathway. And the fast pathway continues on to the AV node, the his bundle, and the ventricle. It also conducts and conceals into the slow pathway and blocks it. Now contrast that to the middle and right panels on this slide, where you see a PAC, a premature atrial complex, come in. You'll note that the PAC fires, it reaches the fast pathway, but it's refractory because it's too early. It hasn't recovered and it cannot conduct. It can conduct down the slow pathway, and there you see the PR interval prolong on that second beat. And what that does is, because you've set up a block in one input to the AV node, and you've conducted through the AV node down into the ventricle, if you turn around in the AV node and climb back up the fast pathway, so you have an antegrade limb going down the slow pathway, the retrograde limb coming back up the fast pathway, that sets up a reentrant circuit, AVNRT, which we see in the figure on the right side. And that sets up this fast tachycardia, which could be extremely symptomatic, and such we should intervene and help these patients, be it non-invasively with medications or invasively with catheter-based ablation. And here's sort of an EKG that you want to have hanging up in the clinic wall so that you could really keep this on your radar when you have a patient that comes to you with symptoms such as palpitations or feelings of flutter in their chest and lightheadedness. Notice in V1, as we talked about at our decision trees, this R prime. It's that P wave that's coming smack on at the same time that the QRS is falling. So it's that little extra blip at the end of the QRS. Also, in one of the inferior leads, AVF, you see a pseudo S prime, and that's again the P wave coming right after the QRS. This is another slide that you want to have posterized in your mind, because these are the patients that could have sudden cardiac death, and these could be young patients, they can be patients of any age, but a patient that you want to make the right decision on the first time, because the ramifications can be lethal. You'll notice that there's an irregularity to the QRS. That's the first clue. The second clue is the QRS width is varying, it's changing. And this is our Wolff-Parkinson-White syndrome patient. Here, the irregularity plus the widening of the QRS should set off an alarm, because if a patient's in atrial fibrillation with pre-excitation, where the rates of the atrium could be 400 to 600 beats per minute, if that pathway is slick enough, it's going to go to the ventricle and degenerate to VT, VFib. It's important here that these patients might be extremely symptomatic. And if their first stop is in the primary care office or in the emergency department, it's utmost importance not to give these patients an AV nodal blocker. Now, we talked about the importance of defining flutter, and especially if you have negative flutter waves in 2, 3 in AVF and a positive flutter wave in V1. So we're connecting two inert structures, the tricuspid valve annulus to the inferior cava. By doing that, we effectively take out the area that's responsible and necessary to have that atrial flutter circuit going. Thus, with catheter ablation, typical atrial flutter can be targeted in this manner and lead to a high success rate and a high chance of curing the patient. Also in the article, we do give an overview of atrial fibrillation, but we wanted to just emphasize a few very important points about atrial fibrillation. Number one, atrial fibrillation is not a life-threatening disease. Everything we do for atrial fibrillation is to improve symptoms and quality of life of the patient, and that's extremely important. But this should be emphasized with the patient. Second thing that we all fear as cardiac electrophysiologists, as well as patients, is stroke risk. That's the big thing that we're worried about with atrial fibrillation. So you'll see that we lament to a CHADS VASC score, which is a risk score of how likely the patient is, regardless if they're in atrial fibrillation or not, that they would develop stroke or stroke-like symptoms from this. And thus, that discussion should be had with the patient, because anticoagulation, irrespective of what treatment we do for atrial fibrillation, is utmost and paramount importance in someone with the syndrome of atrial fibrillation. A third point is, with atrial fibrillation, there's several strategies you could take. It's important, though, to define if someone's having atrial fibrillation for long periods of time and they've developed rate-related issues that can weaken their heart and have caused them to go into what we call a tachycardia-induced cardiomyopathy. I hope you enjoy our review article, which goes in much greater depth and detail than what we've gone through today. But we wanted to also provide a video illustration to go over and sort of bring to life a little bit our review article.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.